On Zoom. Thank you for joining us. And those of you here in the room, just a reminder that if you're on Zoom, if you would mute when you're not talking, that really helps with the transmission. And then when we come to the time of question and answer, which will be at the end, you'll need to raise your hands and you'll need to raise your hands. And then we'll give you the microphone if you're in the room, and we'll unmute you. If you're
We can't unmute them. They have to.
You have to unmute yourself,
Yeah.
okay? Is that clear? Yeah. So I'm really delighted to have Patty with us today. I had a little interaction with her with regard to some of the hospice work, but I really want to introduce Ken Benson. Reverend Ken Benson will introduce Patty since he's worked with her a lot. So, Ken?
And here's our camera, just so you know.
Okay,
So you-
I'll move over here so you can see me, Patty. You don't know what I look like. I'm so glad Patty agreed to do this. I worked with Patty. Patty and I worked together for probably over a year in hospice. And I have to tell you, I've worked in my lifetime with a lot of social workers, but she is by far the best social worker I ever worked with. And I'm just so delighted that she was able to take her lunch hour today and come and be with us, because she's at St. Joe,
St. Joe's, yeah.
St. Joe Hospital, working as a social worker today. So with that, Patty, we're going to let you go, and she's going to have control of turning the pages here. And you all got it on the email today. So if you want to go back and look at it, it's on the email, and you can go back and look at it. Chad, you got something?
No, I just.
Okay. Thank you.
Record, right?
Yeah, it's recording already.
Yeah, it's recording. So go ahead, Patty.
Okay, thank you. Thank you so much for inviting me to speak to all of you. Ken asked me to develop a presentation that addressed I guess process that you all might face. I struggled with the title. I came up with aging process. I don't really put a number to aging because it's really dependent on everyone. It's very individual. But I think overall, what does that even mean as somebody, let me see here. Why isn't it moving? There it goes. As somebody ages, and like I said, it could be at any age. So everything that I'm talking about is really dependent on a lot of factors, right? Medical conditions, possible change with cognitive capabilities. But where I usually like to start in providing education and preparing is legal documents. And I'm sure a lot of you are familiar with preparing trust, living wills, but sometimes people don't really understand the importance of medical power of attorney. So that's thrown around a lot, especially when you go to the hospital. Every hospital is required to ask if you have a medical power of attorney document completed. There's a lot of misconceptions of medical power of attorney. Sometimes people think when they fill out that form that they're giving up the ability to make decisions for themselves. And sometimes the person that is appointed as medical power of attorney believes that they can make decisions for that person at any point in time. What's important to understand about medical power of attorney is that it is only implemented when the person is not able to make decisions. That is based and assessed on by the doctor that's providing treatment at the time. So say you're in the hospital and you do a form, say you're here at St. Joseph's Hospital and they ask you if you've completed a medical power of attorney form. You say no. They have the forms here, every hospital does. You can complete that form while you're here in the hospital. Sometimes it can be limited to that event. So it's really important to know if you've completed a power of attorney that's medical, is there a time frame that it's actually valid for? A lot of people in preparing trusts, a good attorney will talk to you about just a standard medical power of attorney. So there is no time frame that it's effective for. So at any point, if you appoint somebody, your spouse or one of your adult children as your power of attorney, when you are not able to make decisions, then that would be recognized. What's also important to realize with medical power of attorney is that it does not carry over to financial matters. So somebody who is appointed as your medical power of attorney couldn't say, go to the bank. If you were, say, in the hospital, not able to take care of certain financial matters, the medical power of attorney could not do those for you. A lot of times the hospital will ask if you have a living will. Living wills are helpful to help guide the power of attorney. If you haven't had a discussion with your medical power of attorney of what preferences you might want, meaning course of treatment, what you would want as far as medical intervention, resuscitation, CPR, things like that, tube feedings, if those decisions had to be made. What a power of attorney can do, though, let's say that you were in the hospital and then you required to have to be transferred to, say, a skilled nursing facility for physical therapies. A medical power of attorney can actually sign that patient or that person into various levels of care. So for example, power of attorney can sign in or consent for care at a skilled nursing facility, at a rehab facility, in the hospital, at an assisted living. So all of those level of cares. However, where the limitation comes in with medical power of attorney is that that person cannot sign that individual into, say, a level 1 psychiatric hospital. Cannot do that. And I'll talk a little bit about why that's important to understand. So guardianship is a really big court appointmentship. Guardianship means that that person is incapacitated. And that's a really, really strong term, incapacitated. That means that a psychiatrist has completed an evaluation and has determined that this individual cannot make any decisions for themselves. Incapacity is a high level that somebody can be determined because it's there to protect somebody's rights, right? We don't want anybody just being determined incompetent. So it is required by a psychiatrist to conduct a psychiatric evaluation to say that that person is incapacitated, cannot make any decisions. To obtain guardianship, that does go through the courts. So the person that is unable to make decisions is appointed an attorney to advocate on their behalf to protect their rights. It is a long process. Even though there is an emergency guardianship process, that still by statute, by our law, takes a minimum of 2 weeks. And that's in place to protect individuals from just having anybody take power over that person, because guardianship enables that person that's appointed guardian to make all decisions. However, when you're getting documents in order, a good attorney will tell you that if you do go through a guardianship, that you have to include mental health powers. A guardianship typically only permits the guardian to make decisions medically. So then that goes back to just making decisions to put somebody in the hospital at different levels of care outside that hospital, but not if that person needed psychiatric care. So as a person ages, mental health powers become very important. And again, I'll talk to why that's important. Financial power of attorney. That's also something that sometimes people tend to overlook because a lot of times people will have shared accounts or somebody will have access to that account. However, if something should happen to, say, the main person on that account, without having financial power of attorney, it still can limit. Let's say you go to an attorney and you do complete financial power of attorney, but the person is banking at Chase Bank, for example. Chase, all financial institutions have their own forms to access somebody's account and to recognize power of attorney, financial power of attorney. So again, there's different laws in place and process to protect a person from just having anyone have access to somebody's account and make decisions to move money around. But if you are prepared preparing trust and documents. These 3 documents are ones that a good attorney in family planning will include in your trust in all of your documents. I know that when I work in the hospital, when I'm working with individuals, I'll ask them if they have any one of these documents. And it's so nice when somebody gives me this book that's prepared by an attorney and it has all these documents. It makes it so easy for family to know what that person wanted, who they appointed, and the process just is really simplified. So that's kind of the basics to start with. Stages of aging. That's a broad term that's used across the board in geriatric medicine. There's actually, I think there's really just 3 stages of aging. There's independence, right? Where somebody is really, or interdependence, where somebody's kind of needing some assistance. Again, this is very independent for everybody, right? Where, where independence is, right? Oh, does somebody have a question or is that just feedback? Because I'm hearing myself all of a sudden. Okay, now it's gone. Okay.
That's feedback.
Oh, okay. So independence, like I was starting to say, typically lasts through ages 50s and 60s. We're seeing some individuals, of course, be able to be independent much further past 60s. As we lose independence, it's significant because that's how we lose our self-identity. Little things that a lot of people take for granted, being able to drive, being able to ambulate independently, prepare a meal, shower, bathe. I don't think people realize how much energy that actually takes to complete those tasks because they're things we've done all of our lives and it's just something that's automatic. So as we start to lose those the ability to complete those skills, that's where we can start seeing depression and mood changes because then we become interdependent, becoming dependent on others. Again, people have to kind of look at themselves and reestablish a different identity and accept that care. Once we kind of move past interdependence, if that person continues to kind of lose physical abilities, then we go to the stage of dependency. So that's where somebody's really not able to take care of everyday tasks. It's probably somebody that needs some help in the home. The spouse or family member are coming in to provide assistance with meal prep, laundry, housekeeping tasks. Crisis management is when the person is past dependency, meaning that there are sometimes behaviors that occur that the person's just not able to be managed in the home. And so then you're looking at possibly placement outside the home. And sometimes, depending on medical condition, we're looking at hospice services or palliative services. This is one of my favorite sayings. I work with a lot of individuals that have different levels of dementia. If you learn to listen for clues as to how I feel instead of what I say, you will be able to understand me much better. I use this a lot with staff that I train in working with people that are diagnosed with different forms of dementia, because sometimes that person is there. We really have to be in tune to understand how they're feeling because they are still able to communicate. Is just finding the right approach for that person. So I thought that I would talk a little bit about dementia because in my job, I work with a lot of patients that come in. Family members are bringing their loved one in and saying that the person has a mental illness, but they were just diagnosed dementia. And I think they're kind of intertwined, mental illness and dementia, but there is a very significant difference between mental illness and dementia. Mental illness is an actual condition that changes thinking process, emotion, and behaviors. It is affected positively a lot of times by medication intervention. So say we have somebody with depression. A lot of times we know that that's a chemical imbalance that's going on. And with the right medications, we can stabilize that mood. Dementia is different because that's actually an impact on your brain. It's affecting memory, communication, and also bodily function, whereas a mental illness does not go that far. Dementia can be sometimes affected with medications, but because of the cognitive impact on the brain, it's deteriorating. It's gradually deteriorating the process of the brain. So sometimes medications aren't effective in the way that it can be effective with the mental illness. So I always like to bring the definitions of dementia versus mental illness and why I think it becomes frustrating for families because they believe that it is a mental illness. We can prescribe a medication and affect change on some of the symptoms associated with dementia. We are seeing that with an onset of dementia, especially the beginning, we see depression. And again, that's tied to when somebody is losing the ability to do those day-to-day functions that sometimes we take for granted because the person is aware that there's a change, they're aware that they're losing that function. And so we do see depression. So with dementia, we will treat with an antidepressant sometimes or mood stabilizer to help that person with depression. Okay. So what I see in my job is that when somebody is diagnosed with dementia and it's progressing and we see changes with that person, they're not able to recognize, say, family members. So we're seeing memory problems. Sometimes we're seeing delusional behavior. Sometimes they're hearing things that, you obviously do not see as well. So it's very challenging. So I always like to coach families on how to interact with somebody that is suffering from symptoms of dementia. It is trying, I think, if you're the primary caregiver, because it's frustrating to see that somebody might not recognize you. They also might exhibit a whole range of emotions that are difficult to cope with on a day-to-day basis. But the one thing I always tell caregivers is that grounding yourself, taking a breath, acknowledging that this is very stressful and that the key is to also stay very warm, positive. Somebody that is diagnosed with dementia, somehow they're very in tune. They can pick up on the other person's emotions. It's almost like when you're caring for a baby, the baby can pick up on emotions of the parents. So it's the same thing with dementia. If you're stressed, if you become irritable or agitated with the situation, that's gonna, the person with dementia will pick up on that. So it actually kind of agitates the situation more. So what we also know with individuals with dementia, any kind of loud noises, TVs, radios going, if you're trying to hold a conversation with that person, it's hard for that person to tune into what you're saying because they are easily distracted. One way to think about it is that this person's brain is decreased function. So they aren't able to multitask various sounds, visual events that are going on. So we want to minimize as much distractions as possible, especially because those distractions could possibly startle that person and then kind of spark, say, a delusion or possibly any kind of hallucinations. So we do want to have a more calm environment for that person. Always when somebody is kind of with progressed symptoms of dementia, when you approach the person, it's really good to identify yourself because sometimes that person has very impaired short-term memory and does not recall who that person is. So we always ask people to introduce themselves. So if you have a caregiver in the home or people are visiting, that they just like identify themselves so they know who they are. Long-term memories stay with that person the longest. So maybe cueing in to something that might spark long-term memories for that person can help. The other thing is to speak very slowly so that they can process what you're saying. Because again, as the brain function decreases, the person is going to take a little bit longer to process what is being communicated to them. So use shorter sentences, smaller words, The other thing that's really hard to do sometimes, and I know I do it on the unit, is don't use run-on sentences. Because that person isn't actually communicating, say you would with somebody that is not impaired cognitively. Sometimes I find I just keep talking and talking and talking and talking, and I'm just rambling. So it's patience, it's using smaller words, shorter sentences, and to be direct. Because the person, again, cognitively can't abstractly think. So going back to very concrete terms, so the person can understand what you're talking about. So usually I use concrete words and I point to objects so that they have the visual and also verbal connection to what I might be talking about. I also try to avoid assumptions. And when somebody presents to our hospital with somebody who has progressive dementia, one thing that I do notice, the person might be saying that at home, this person seems very irritable, agitated, throwing things. What happens is that the family member, the spouse, starts making assumptions of what might be happening. And that just adds to irritation for the person. And so then you will probably see more agitation and more irritability. So it is really difficult because, again, it's patience to work with somebody that has a diagnosis of dementia. So active listening is really the key. And whenever I say active listening, a lot of people think, why do active listening? Active listening is very, very difficult because, again, it requires patience. Sometimes people that are active listening with somebody with dementia is nodding a lot. And I don't know if you've noticed somebody with progressive dementia, if you're nodding a lot, that's distracting. And sometimes the person thinks that you're minimizing or actually not listening to what they're saying because they find it distracting or it's dismissive. So nodding, yes, but maybe not a lot, because again, that nodding could give that person the impression that you're kind of pushing them along, that you're trying to rush them to get words out. So usually I use small words like, I understand. But again, letting that person feel the patience that they have that opportunity to really talk, and then just giving positive, empathetic confirmation that you're understanding, maybe repeating back what they said so that they do have validation that you've heard what they said. Also not trying to stop what they're saying, cutting them off, using big words or open sentences like why. That's too abstract for somebody sometimes with a diagnosis of dementia because they can't answer that. Again, they can answer in more directed forms with short questions, smaller words. Okay. The other, I think, important approach is to not use logic. I just worked with a man whose wife, the dementia has really progressed, and she is very aggressive and agitated at times, especially, towards the later part of the day, early evening. She is experiencing some delusions and saying that there's certain people there in the home. And he told me that he knows those people aren't there, but what he's doing is trying to use logic to reason with her. He said that he would just tell her that's not true. They're not here. I don't see it. That's not going to work with somebody with a diagnosis of dementia, because that person, that is their reality. Using logic and arguing with them is only going to get that person more agitated. They could then escalate to trying to hurt that person or hurt themselves. So logic is out the window. The best approach is to validate what they're feeling, go with the delusions that they're saying, and again, help them feel that you're validating what they're saying, because you will not change what they're saying. So logic is out the window. If somebody's very upset, the best approach is to look concerned, validate again, say to that person, it sounds like you are upset right now. And then usually that opens the discussion. The person will tell you why they're upset. And one thing is that if they're looking for something specific, you can distract the person by saying, for example, tell me about your mom. A lot of patients that I work with are always looking for their parents. It goes back to they're trying to find their mom or their dad. Saying to them, well, they're deceased. That's not going to help with that person. They'll probably get more agitated, very upset. So again, cueing into their long-term memory, because that stays in place the longest. Distraction by asking about those memories will help calm that person down, because it takes them back to a place that they feel comforted. If you are talking to somebody and they are getting upset, one thing that I do say is, I'm sorry that I'm bothering you. I didn't mean to do that. And then what I usually do is exactly what I wrote, is just help me out for a couple minutes. And I just have a couple questions for you. That usually helps calm the person down. Always validating how they're feeling, recognizing that emotion that you're seeing, that they're exhibiting, always helps de-escalate a person. One of the common things I'm always told by family members is that they're yelled at, being accused of attacking that person, that they're hurting them. What can you do? So again, the best thing to do is to just kind of back away. Again, space. Don't get too confrontational or close to that person. Always calm, soft, soothing voice. I usually go eye level to somebody so that they don't feel that you're towering over them, because as cognitive function declines, eyesight becomes more tunneled. So if you're standing over the person, how they could see that, because their vision becomes impaired, it's tunneled. So they're not able to have that peripheral vision to capture how you're standing. So it can be very overwhelming for that person because of the tunneled vision that could be occurring. Okay. Not being recognized by somebody from dementia is also very frustrating for that person. Trying to convince them who you are, sometimes it's not going to help. What we've seen is that maybe using some long-term memory that could help trigger them. I was watching this video. They're doing a lot more work with music, because music is one thing that stays on our memory for a very long time. A lot of us identify very significant events with music. And so this one woman, her mother never recognized her, only recognized her when the daughter would play a certain song that they shared together. When that song was playing, the patient would remember the daughter. So one thing to do is kind of go down memory lane. That helps jog some memories for people, and then can remember. Sometimes what I do is talk to somebody to get history. I know Ken and I would do this a lot, is again, play on long-term memory. And if somebody's upset too, and they're calling out for, say, their mother, for me, it's always their mother that they're looking for. I will tell them that I'll go see if I can find them, that I would be right back. And then I would come back and say that, I just spoke to that person. They said that they're fine, they're busy. Just give reassurance, because again, I'm not going to be able to convince that person that this person is deceased. The mom is not really going to come. So again, logic's kind of out the window. You work with the reality that that person's in to help them feel safe and reassured. Okay. A lot of times So this person that has a diagnosis of dementia feels that people are following them, that they're chasing them. I had a woman admitted to the emergency room the other day. She was very agitated because she believed that 5 men were coming into her home every night. And so she was extremely afraid. The husband didn't know how to help her. Instead, he would just tell her, no, they're not here. And then she became very agitated. So what I did was just help coach the husband on how to help her deal with those emotions. Suggested that he tell her he got locks now for the door, that he's gotten extra security, that if she sees the men there, that he'll call the police to have them, the police come to address these people that broke in. A lot of times that's just going to bring somebody down and they'll be okay. Then what you can do is distract, either play music, if they liked board games, anything that in their long-term memory that they might have found enjoyable, use that as a distraction to help de-escalate the situation. Okay. One thing that we do see with people with progressive dementia is that they see insects on their food. How you might come to realize that's occurring is that somebody's not wanting to eat. We see that a lot where the person's brought to our emergency room and the family is telling us that they're just refusing to eat. They're not wanting to drink. And so in just talking to that person, we come to find out that they believe that there's bugs or there's insects crawling on their food, or they believe the food is poisoned. And so that's one way that you can find out what's going on. Once we figure out why they're not eating, if it is associated with some kind of delusions, then we can find different ways to solve that problem and then get them back to eating. Okay. So kind of shifting now to healthcare benefits. So, you have a person that might have either dementia that's progressing or chronic medical conditions that are progressing, and you're needing different levels of care. What also becomes confusing for people is your healthcare benefits. A lot of people believe that Medicare provides a lot of coverage, that if somebody needs placement outside of the home, let's say the dementia is now progressing and the person needs 24-hour care, and the person needs to go to an assisted living or even a skilled nursing facility. A lot of individuals believe that Medicare will provide those benefits. Medicare does not. I'm sure a lot of you know that you can sign over to a managed care plan. Sometimes you get more benefits that way. Traditional Medicare, as you know, is an 80-20 split. Medicare has very designated timeframes for certain benefits. So let's say that you're in the hospital and you had a fracture or a fall or something, and the doctor says you need physical therapy. Depending on how many hours you can participate in physical therapy, you might have to go to a skilled nursing facility to get therapy. Therapy is not every day. It's only so many hours a week. The length of stay usually for a nursing home is roughly 3 to 4 weeks. One thing to keep in mind is that your Medicare benefit for, say, therapy is only 28 to 30 days. That's it. If you exceed that, then you go into copay days. That's the same with the managed care plan, because managed care plans have to follow Medicare guidelines. And a lot of people are not told this. So if you or your spouse are admitted to a skilled nursing facility for therapy, one thing I always advise is that Medicare demands that within 24 hours of admission, there has to be a treatment plan developed. I always suggest that you say you want to discharge in 2 weeks, because no matter how many weeks you're there, when you are discharged, you are not going to be at an independent level, because that's just not going to be possible at that level of care. So then in-home therapies are arranged, or outpatient therapies. So the best thing to do is to tell that facility that you want to stay under 2 weeks. And then you're saving your benefit, because that 30 days is what you have. If you use against it, you have to not utilize that benefit for 60 days or more to restart. It gets very expensive if you get past that and you go into copay days, because as you accrue more days that way, then you can get to the point where it's totally out of pocket. And that gets very expensive. Okay. Medicare does not pay for out-of-home placement. So if you need a group home or adult care home, assisted living, or admission to a skilled nursing facility care, Medicare does not cover that. Medicare does not cover what's called custodial care. So it will pay, Medicare will pay for in-home services, but it has to be skilled. Because again, Medicare does not pay for custodial. So a nurse can come to your home if your doctor has identified a skilled need. So that could be wound care. Let's say diabetes are out of control, a nurse can come in, but Medicare only allows very specific nursing visits. Okay, it's limited. Medicare does pay for in-home physical therapy and occupational therapy. So that is something that you can get if a doctor does recognize that. Medicare also pays for in-home safety evaluations. So let's say you were somewhere for therapy, for physical and occupational therapy, and you are interested in making sure that the home is safe. For that person, they might need grab bars, raised commode. Medicare will pay for a therapist to come out and look at the home to make sure that it's adapted, okay? Acute psychiatric hospitalization. That one always comes up because we'll have patients come to the emergency room saying that their loved one is just not able to be managed at home and they want the person admitted. So acute psychiatric hospitalization there's criteria. It is limited to acute. So what's frustrating for families is that if somebody is experiencing certain delusions due to dementia, a lot of times that person might not still meet the criteria to be in the hospital, because it has to be an acute event that we feel, the psychiatrist believes, that we can address with medications in the hospital. And a lot of times people will ask us to admit somebody because they just can't care for them anymore in the home. And insurance just does not reimburse for that. It has to be an identified acute psychiatric need to be in the hospital. Long-term care. Long-term care is a benefit that is actually available in Pima County. It's in the state of Arizona, so each county has the ability to apply for that. It's a great benefit. It's along the line as Access or Medicaid. It's based on income. This is the highest eligibility right now for a couple or even individual. So an individual can make over $2,000 a month and qualify for long-term care. Why this is important, and I always educate families on this, is because long-term care pays for what Medicare does not pay. Long-term care pays for transportation. Long-term care pays for any level of out-of-home placement. That could be an adult care home, that could be assisted living, skilled nursing facility. It pays for all of that level of care. There is a percentage that the patient might have as responsibility, but it is in nowhere close to what you might pay out of pocket, because an assisted living can cost anywhere over $6,000 to pay per month. Long-term care would pick up that bill. It's an incredible benefit if you can qualify for that. There is two components. It's financial, and then there's medical. So like I said, for an individual, that person can make $2,400 a month and qualify. For a couple, it's over $4,000 a month. And then medically, as long as the person is unable to do a lot of those daily activities on their own, they should be able to qualify for long-term care. But it's an excellent coverage. It also pays for in-home attendant cares. In-home attendants to be in-home. It's not 24/7, but it does help out. So in-home caregivers, a lot of times families aren't aware of what this service is. So if somebody has a new diagnosis of dementia, for example, and family just needs some help with some day-to-day care, personal care, in-home caregivers are an excellent resource. It is different than home health. There's various just specific in-home caregiver agencies. All they provide is in-home caregivers. When you do pursue this service, you do want to ask what level the caregiver is licensed, because there are the lowest level of caregivers. Those individuals do not have any kind of accreditation, meaning that they're not certified maybe in CPR or different levels of medical knowledge. It would be similar to just say somebody within the family that's sitting with their loved one. And then there's more trained caregivers that can be in your home. That is not covered by Medicare or any insurance. That is an out-of-pocket expense. It can be expensive because caregivers could cost anywhere from $25 to $28 an hour, but there are some agencies that do provide assistance with that, with attendant cares in the home. So adult group home, I don't know if you all know what that means. I always like to discuss that. Adult care home, there's also different levels of that in the community. There are some group homes that are not licensed, meaning that these are just individuals that are renting a home out to individuals. You pay them rent. These are individuals that in no way hold a license. They should not be overseeing anyone's medications, because these are just individuals say, I decided to rent you a room in my home, and I'm not licensed with the state or the county. So they're not held to any type of medical accountability to the county or anyone, to the state. There are licensed adult care homes. A lot of times they are classified as assisted living because they are licensed that way through the county. So they are held to surveys through the county and other surveyor agencies to make sure that their staff are trained, that they're following medical guidelines within that home. So you just need to be careful when you're looking at that kind of level of care home, that you're sticking with more of a licensed kind of care home. Assisted living, that's a big word now. It's gotten very big in the community. There in Green Valley, there's new assisted livings that are kind of opened up on the outside of Green Valley. They specialized with little casitas that provide smaller staff ratio for individuals that either do have a known mental illness or progressive dementia. The homes are wonderful. The casitas are great. The concept they have is excellent because, again, it's a small staff ratio. All the casitas look like a home. They do family style meals. Again, though, this level of care, the cost is based on services that you have. So it's usually 3 different levels of care within that facility. The lowest level of care, though, is usually a few meals that are included. It's somebody that's pretty independent, but would benefit from a facility that offers some on-site, assistance if needed. But even at the lowest level of care, you're still looking at close to $4,000 a month. It's very expensive. Skilled nursing facility, the highest level of care that is outside the home. And I'm sure you've all seen a lot of different nursing facilities. Those are probably the most challenging right now with COVID occurring. Skilled nursing facilities are just challenging because it's probably not the most optimal place that you would want to put your loved one, just because of the nature of the nursing facility. In the nursing facilities, they try to provide activities, try to keep a person occupied throughout the day. But that's where I see a lot of individuals becoming depressed because of the environment, lack of interaction sometimes. Especially if the facility does not have a strong activities program. So that one's probably the toughest. It's also extremely expensive. So again, it's important to, if you aren't able to long-term plan, then hopefully qualify for long-term care, because that would pay for those levels of care. So supportive services, I always like to go over palliative care and hospice care. Palliative care sometimes gets confused that it's also end of life, like hospice, but palliative care is very effective. Palliative care, somebody can kind of come in and out of palliative care. Palliative care is a support service where the team does come out to the home. The target of palliative care is to assist that individual with a new diagnosis that is resulting in pain, uncontrollable pain, or just a chronic medical condition. So palliative care is similar to hospice in that you have an overseeing medical physician, you have nurse practitioners, and you have nurses. And a lot of times you will see a social worker with palliative care, but the difference is that they're not focused on end of life in the sense that treatment is stopped. Palliative care is considered very active service. But again, the focus is to decrease pain and try to increase that person's functioning level. Hospice is different than palliative in that hospice is end of life. Hospice is covered by Medicare. Hospice or Medicare provides everything under hospice: medication, all of the equipment that you would need. Hospice used to be several years ago that we had to give a very definitive diagnosis of 6 months or less. It's widened in the sense that somebody could be in a hospice program up to a couple years. However, there is an end date. If somebody is really not progressing in end of life, then the best thing to do would be to disenroll from hospice and maybe go to palliative care or a different form of service, because you don't want to use up all of your hospice benefit, because under Medicare there is a time frame. It's typically about 2 years, and you don't want to utilize all of your hospice benefits if not needed. And I think one of the misperceptions about hospice is that it's 24-hour care. There are 24-hour services available under hospice, but that would be based on the clinical presentation of that patient. And there's different hospices here in Pima County that do have hospice units. A lot of times, if you're with certain hospice agencies, they utilize skilled nursing facilities for their inpatient care. One thing to keep in mind is that if the goal is to keep the person at home, you can receive 24-hour coverage in the home, depending again on the clinical presentation. But one thing, if you're looking at hospice service, is to ask that hospice agency if they have their own inpatient unit. If your loved one needs inpatient services, where would that person be placed? Because, you know, some people don't want to utilize a skilled nursing facility to put their loved one there if they needed inpatient, especially right now with COVID. A lot of the nursing facilities are locked down, so families can't go in. So when Ken and I were active with hospice, that was probably one of the most frustrating parts, is that if somebody had to be inpatient and they had to go to a skilled nursing facility, then they weren't able to have family or visitors. So they were isolated. So those are the questions you want to ask when you're looking at hospice services. And at the hospice agency, asking their social worker what services that they can link you to, because there's a lot of community services that are available to help support that person in the home, if that's the goal. Because again, it's not 24/7, but if the goal is to keep the person at home, you can definitely be creative to bring services into the home. So I found this quote by Sophia Loren, who I think said it well. There's a fountain of youth. It is your mind, your talents, the creativity you bring to your life and the lives of people you love. When you learn to tap this source, you will truly have defeated age. And I always joke with Ken that I do live that day to day. I was joking I have a new grandson, which I find amazing because I think I'm only like 24. So I find it very amazing that I'm a grandmother at such a young age. So I think it's very wise words. So anyway, that's the end of my presentation. So I don't know if there's any questions out there because I kind of threw a lot out there. So.
Okay. Go ahead.
Thank you for your presentation, Patty. My name's Ruth Schroeder. I spoke with you many, many months ago. I've been through the cycle. I think the biggest problem that I see, you're a social worker in the hospital, and it sounds like you are really working with the families and with the patient. We ended up in a hospital where either I didn't know what questions to ask, or the social worker was distracted.
Mm-hmm.
And the young man, well, my stepdaughter and I said the young kid who talked very briefly about hospice, and the doctor did not speak at all. We didn't know what direction to go. We didn't know where to find the service that we needed.
Mm-hmm.
And so we were lost. And I know that there are others that fall into this pit, or whatever you want to call it, of how do we find what service is needed for a particular person?
That's a good question, because I do see that here in the hospital, because I'm on the psychiatric team and I'll become involved, but there's an identified social worker and case manager, and I see exactly what you're speaking of, where nobody's taken the time to help that person navigate the system, and it is extremely complicated. Because if you're already talking to the social worker and they're not helpful, I used to refer people to PEMA Council on Aging, but I've heard some feedback that that hasn't been helpful for a lot of people either. So Ken knows that I'm always willing to help. If anybody there is hitting roadblocks and not getting the answers to their questions, or just need help, you can always ask Ken or someone there, and they can always reach out to me, because I'm always willing to help you. Because it's not an easy answer, because if the person that's there in the hospital that's identified to talk to you and they don't know,
Well, the choice that the social worker gave us at the hospital was pick a facility.
yeah.
Not, this is what the expectations are, this is what should happen. We got none of that. And I know that there are others who've had that same kind of a situation. So,
Yes.
I mean, if the social worker would have talked about, well, the doctor is saying this about your husband, and maybe they don't want to deliver the bad news to you.
Right.
And the only person that finally helped us was the social worker from the doctor's office, after he had been admitted to a nursing rehab facility, which did nothing for about 2.5 weeks.
Right.
To say he's going to be discharged, said to us when we went to talk with the social worker at the facility, you may want to ask them about hospice.
Right.
And his response was, oh, that's a good question. Anyway.
Yeah. One thing that is, if you're in the hospital and they're saying that, your loved one needs therapy, like physical or occupational therapy, the best person to always talk to is the physical therapist. They will tell you everything. They can also give you good insight on which facilities are better than others, but they'll give you the straight shot on what they're thinking. Because sometimes, like you're saying, you don't get that from the social worker, the doctor, or the nurse, anyone. But if you're working with the physical therapist, they will always tell you straight up what's going on. They can also tell you what they're thinking the length of stay is, when they're thinking of discharge. That the therapists are always really in tune, if you're not fortunate to have a social worker or case manager that's in tune with what's going on.
There's no therapist either.
Yeah.
I think, Helen, did you have a question? Helen, you need to unmute yourself.
Okay, I am unmuted. I just wanted to say how helpful, how useful this is. My husband was diagnosed with dementia, and then he was put in hospice care. Actually, it was end of life care.
Okay.
That's really what it was, but that's when I discovered how much they do for you. They were an enormous amount of help to me. Yeah.
Yeah.
So I really like this presentation of yours, and I hope you give it a lot of places because it's so full of good information.
Thank you. I appreciate that.
We've got it recorded, so we have another hand here. I know Patty, you've got a time limit here, so do you have time for what, one more or two more?
Oh, no, yeah, go ahead. I'm okay.
Hi Patty, I'm a nurse. I work full-time at a hospital in Tucson.
Okay.
And 1 year recently, when I worked for hospice, the biggest problem I found was some of the primary doctors are very reluctant to sign off their patient to go to hospice.
Yes.
The reason is that they can no longer bill. They're left financially out of it altogether.
Yes.
So that kind of leaves the family up in the air. The last person that asked a question said, yeah, there's some great things with hospice, and absolutely, that's a big asset for the family when you can convert to hospice. But you've got to convince that doctor to sign off. So what we did at that point was we just recommended that the family go to hospice and sign up and just bypass the doctor. That was the best way to get the service.
It's very true. I'm glad you brought that up because you do not need a doctor to write the order. If you really want hospice, you can call a hospice agency yourself because the hospice can get orders themselves. It does not have to, it's not reliant on your primary care physician. Thank you for bringing that up.
Other questions from the group here? Okay.
Yeah, I just want to make one more comment. I think I'm unmuted now.
Oh, no, you're unmuted. Yeah.
Go for it, yeah.
Yeah.
ahead.
It was my husband's doctor who put in the order for hospice care, and he said to me now, he said, if there is a time limit on it, and he said, if that happens, all I have to do is place the order again. He said, don't worry about it.
Yeah. Yep.
Okay, Chris.
I would like to know where we could, excuse me, get more information on the Arizona long-term care coverage.
Okay, let me give you, you can go online. It's not really helpful, but I can give you the phone number to actually call them. But you can pull it up online. Just Google Arizona long-term care. But it might be limited. Even Pima Council on Aging has a link about long-term care, but I find all of that cryptic in the sense that, you know, they don't really tell you the ins and outs of it. So with long-term care, the key points is that financially you have to meet, right? So for an individual, you can't have more than $2,400 a month, and that's net. So I had a patient that I was trying to get on long-term care, and because of her gross amount, they kicked her out. She ended up being over by $200 by her gross amount. And so I argued with the all-tex worker because she actually does not bring that in, right? That's her gross amount, not her net. But her pension plan kicked her out by $100. So it's gross amount of 2004. So for a married couple, it's 4,200. So if you're under that amount, you'll qualify financially. Medically, you have to have a medical condition, say dementia. It could be, let's see, what else could it be? It could be a medical condition that is impairing that person's ability to manage the day-to-day functions. So to qualify for the medical component, one guideline to look at is, can that person go to the bathroom by themselves? Are they wearing briefs? Can they take a shower by themselves? Can they prepare a meal by themselves? So all of those day-to-day functions, if they cannot do those on their own, then they'll qualify for long-term care. So it's always, my thing is that it's always worth calling long-term care if you think that you might qualify medically, because all they can tell you in a screen is no, but they could say yes. And I can give you guys the phone number for long-term care. They're very, very helpful. They've been doing all of the applications over the phone, but all of the eligibility workers are very, very helpful people. They're very kind. If you even have questions, they can answer those questions for you on the phone, because the first person that answers is kind of a general staff person, and their job is to just help answer questions. So they're very, very nice. And that phone number is 520-205-8600.
That's very helpful. I really appreciate that, Patty.
Uh-huh.
Yeah. We have another question or comment somebody wants to make? Yeah, okay.
Very short. I just want to say thank you. What your information has been wonderful.
Thank
And
you.
Starting down that road at our house, and so it was helpful.
Thank you. Well, all of you know that if you need any assistance, Ken knows that I'm just a phone call away, and I'm always, always willing to help any one of you out. So
That's an amazing offer. So thank you so much, Patty. I
Thank
really
you.
appreciate it.
thank you all for
Right.
inviting me. I really
Thank you.
appreciate it. Thank you.
For
Okay, bye.
Okay, thanks so much.